Good morning, everyone, and thank you for joining this webinar on the ending emotional breathlessness and chronic respiratory disease. I'm Dr. Devi Sundar, and I'm going to be your host today, facilitating the session for you and sharing that important work, what we did and found out from the national survey in the population of UK population of 2,173. And the interesting data, what we discovered about the awareness level on the mental health in chronic respiratory disease. To formally introduce myself, I'm Dr. Devi Sundar, Integrative Mind Body Consultant and a founder of Teletherapies and Mind Body Synergy. And this survey has been commissioned by Teletherapies in October 2025 to YouGov, and I'm going to share some of the data in it, and I can actually confirm that I've listed here on the screen. Publication has been already published last year in November. So the link is on the screen and it is displayed throughout the webinar slides. So you can snapshot or screenshot the link, or you can actually send a request to send this publications to your inbox, and I can do that later after the webinar. So without any further ado, I'm just going to kickstart the webinar as we have to go through many slides. So before I could actually pressure you with all the data, I would like you to take a moment, pause, and notice your breath. Take a moment, relax wherever you are, and either closing your eyes or with your eyes open, just notice your breathing. Whether your breathing is calm or shallow or tight or relaxed, just feel your breathing. No changes needed, as it is in your moment, wherever you are. Now, think about the same breathing when you're in stress. How does your breathing pattern changes? When you're in anxiety, how does your breathing pattern changes? And when you're in a public speaking, which most of us would have encountered, that familiar catch in our throat, that's something which is actually helps us to understand the connection between our emotions and our breathing. So today I'm going to share more about our work in terms of emotional breathlessness in chronic respiratory disease. There is a mind-lung connection, and most of us are unaware, which I can confidently say because our UK survey, nationwide UK survey, have revealed 69% of the UK population are unaware of this important connection of mind and lung, and which is actually the common emotional breathlessness experienced by population of chronic respiratory disease. So emotional breathlessness, as you can see on the screen, is driven by not only physiology of your lung functions, but also by anxiety, fear, or emotional state. And there is a mind-lung connection. The brain and your respiratory system are in a constant dialogue. And this is actually overlooked in the clinical care, which you'll be able to understand as I go through the slides. Now, our national survey, as I given you a hint at the start of this webinar, our survey with the YouGov in October 2025, with a population of 2,173 UK adults responded to the survey, we found out that emotional breathlessness is a component that is under-recognized in the population of chronic respiratory disease. Public is not aware that people with chronic respiratory disease having this anxiety, depression, and the challenges, mental health challenges they go through when they are experiencing this chronic illness, chronic respiratory disease. So for those who are not familiar with chronic respiratory disease, I point out to, most importantly, COPD, chronic obstructive pulmonary disease, asthma, interstitial lung disease, and post-TB COPD, and other conditions related to the chronic respiratory disease umbrella. So this actually then, a survey actually calls for integration of psychosocially integrative pulmonary rehabilitation, which is pulmonary rehabilitation is a lung rehabilitation program offered or prescribed to people with chronic respiratory disease. And that lacks currently the integration of psychological intervention, and the whole respiratory care pathways lack that integration of psychological integration into their care packages to people. So when we talk about emotional breathlessness, people actually ponder over this is a new term. It is. It might be a new term, but we are all familiar with that anxiety, the panic, and fear, which is actually labeled as emotional breathlessness. I've labeled it in one simple word so people can understand that, because our fear and panic are driven by our emotion, and that triggers our physiological and physical responses through our mind and lung axis. So the policies which we are having existing for years, many, many years, like NHS long-term plan and the NICE quality standard 10 and WHO international frameworks, all actually loudly say that we need to focus high standard quality care for people with chronic respiratory disease. But we are in action, are not performing that. We are actually not having that communication to our public how important it is to deal with that emotional breathlessness in people with chronic respiratory disease. So, why this matters? Why am I actually loudly shouting out that we need to look into that emotional breathlessness in people with chronic respiratory disease? Because when we talk about the chronic respiratory disease, our policies, existing policies, focuses and the guidelines and the statement more focuses on the airways inflammation and the lung function test, the spirometry. But when we talk about people going through that pulmonary rehabilitation, which is a lung rehabilitation, doing all the exercises and getting an education for that 8 weeks or the 6 weeks program they enroll themselves to, they are left out with the key skills to deal with the emotions. How this challenge is going to be dealt in that population is a big question, because emotional experience of breathlessness, that is, which I already mentioned earlier, the fear, the panic, or the distress, that actually breaks the trust between the body and the mind and the lung. So that actually then remains unaddressed in this population. And hence, people who went through that rehabilitation program, a 6 weeks or 8 weeks program, their rehabilitation benefits fades away within 3 months or 4 months, and they are back to square one, going into that hospital admission, the crisis admission, where the fear and panic, although their lung functions are normal, have actually triggered them to get help or seek help immediately and a lineup in the emergency departments in our country, in the hospitals. So treating the organ without the person then leaves that the person to have no skills to manage their breathlessness beyond their lungs. So there is a huge gap in the care of chronic respiratory disease presently, and that's what I want to get your attention to. Whoever you're listening, your policymaker, your healthcare professional, or a public, or a person who already struggling with this chronic respiratory disease, I want you to listen, open up your ears for the following slides and understand what is the key data we found out and why it is very important. So our policy, actually, I have been starting to advocate for this policy from the 2024, where I started to deliver the campaigns on the change.org. And the first campaign started in November 2024 was that integrate mental and physical health care for COPD patients in Gloucestershire. Basically, I'm present in Gloucestershire and I've been advocating for people in Gloucestershire since 2024 to focus on this important concept of emotional breathlessness in people with chronic respiratory disease. So, the next petition, which I actually started on the same month or November in the year of 2024, was a UK Parliament petition, also requesting funding a new COPD strategy, including the psychological interventions for people with chronic respiratory disease. And there was a response of 51 signature widely, which is to my surprise, because it's a huge huge issue where our national health service is focusing on, the guidelines is focusing on, but we are not familiar with the mental health challenges in people with chronic respiratory disease, which is a bigger shock when I received the data results. And I also, through our local MP, I've raised the question to the Parliament, and I got a response. The question was raised on the 10th of July, 2025, and the response was received on the 18th of July, 2025. And the response from Ashley Dalton, the MP, said that there is actually a provision of talking therapies for long-term condition. But that is true. I do agree 100% that there was talking services available, but it lacked the specificity or transparency, most importantly, relevant to the psychological interventions to people with chronic respiratory disease. And it is not a generic anxiety or depression we are going to go about with the people struggling with a chronic respiratory disease, which is a health condition. And so, somewhere down the line, we are missing the link or the true importance of dealing with the mental health challenges in people with chronic respiratory disease. And there is an ongoing survey as well in the crisis of emotional breathlessness for over 7 million people in the same change.org started last year, 2025, in November. And these campaigns are not against the government, it is about helping the government to understand and also the public to understand the importance of the health issue, which is lacking the care, and how we can actually better the care delivery to our people and save the economic cost for our nation as well. So, to give you a bigger picture, how much is the burden and why am I actually more passionate about talking this to you? And I wanted to talk to you today is there is 12 million people living with lung disease across the United Kingdom, and it is the third leading cause of death in England and Wales, and 20% of all deaths annually is related to the lung disease. And particularly people with chronic respiratory disease are more linked with other conditions, long-term conditions, the cardiovascular disease, diabetes, and mental health disorder. But yet still, it is under-recognized and underfunded. So the mental health link, which we can't ignore in this population, is is very, very important because 1 in 3 people with chronic respiratory disease have a clinically significant anxiety or depression, and 40% of them have COPD and depression in COPD, particularly meet that criteria of depression, and 36% have this anxiety component in them. So when we are treating people with physical rehabilitation, we're forgetting their mind. And the mind is actually helps the person to initiate that breath. And if the person is having that fear and anxiety and initiating the breath, however you're strengthening the lungs, however you're strengthening or preparing the people physically stronger, the mind is not strong enough to recognize and treat their breathlessness. And it is not only a clinical issue, it's also a workforce impact and health inequity. 1.7 million people are off due to the chronic respiratory disease, which is a major driver of economic inactivity in UK. And 50% of them are related to the mental health issues, and those absence are attributed to the psychological factors. Who bears the heaviest burden? The impact of chronic respiratory disease is not equally distributed. Those with fewest resources face the greatest harm. Deprived communities, higher prevalence, poor outcome, and less access to psychosocial support. And ethnic minorities have the disproportionate burden. They are compounded with the systemic barriers to equitable care. So it is to bring to attention that it is not only a clinical issue, it is also is impacting our economy as well. So now I want you to take a moment of pause and digest all these figures, what I've actually prompted on in the slide to you, and think about, is it really an issue? Is it something which we have to deal with right now? I want you to take a moment. Now, after this moment of pause, I hope so that you have able to digest and reflect back on the slides, which I've mentioned, prompted all the huge data and figures, and understand the impact. So, moving further down, so, as I mentioned earlier, emotional breathlessness, what is that? As I already mentioned, it is the psychological distress, the anxiety or the fear, the panic, which amplifies the perception of breathlessness beyond the physiology of the person, whatever they are having in the lung physiology or the illness physiology that is triggering that breathlessness. So that actually increases their symptom perception. So if a person is slightly breathless, it prompts to perceive that more than the lower level if they have this fear anxiety and poor clinical engagement, like they are not engaging consistently with their 6 weeks or the 8 weeks rehab program, or even the medication. They're not able to engage with the medication or the appointments, what they have with the clinical healthcare professionals. And also that prompts to the reduced quality of life because they're not engaging, then there is actually a reduced independence and more dependent with their families and carers, and lessens their social participation and decreases their well-being as well. So why it matters? As I mentioned, these three particular important points, the increased symptom perception and poor engagement and reduced quality of life, is actually increasing the burden of this chronic respiratory disease and how our NHS is dealing with it. Because NHS is presently not dealing with it as an integrated way. So we have the lung rehabilitation, pulmonary rehabilitation, we have the respiratory care pathways, but the mental health component is not integrated in the respiratory care pathway. And that is where this data is taking you to. And that is where a huge public communication lack is existing. So when we talk about how much NHS spends, just to give you an indication, it's 311 billion pounds total annual burden. It's the combined cost of the productivity cost and what the NHS spends for the chronic respiratory disease in UK. And so this makes a huge, huge case for early psychosocial intervention and integrated care. It is not only economic, but it's also a health inequality case where the chronic respiratory disease is disproportionately affecting the deprived communities and ethnic minorities, and the inequity persists in their access, awareness, and the outcome. And I have published a paper in 2024 where I had a survey service development survey for the South Asian community, where they recognize the importance of pulmonary rehab, but they actually also confirm the communication gaps in the importance of pulmonary rehabilitation and the referrals of pulmonary rehabilitation. And definitely, there is less awareness of mental challenges in the chronic respiratory condition. And in my channel, Breathe and Thrive, I have published a lot of videos, public health videos, to create that awareness of mental challenges in people with chronic respiratory disease. So after this webinar, you can take your time back and look at all the information and understand how important it is to integrate mental health intervention into the care packages of chronic respiratory disease. Psychosocial needs is consistently deprioritized in these populations. So we have to make a point that we are thinking differently. We are thinking in a way where we can better the care to our population. So, as I mentioned earlier, the system problem, the NHS model, what it currently focusing on is the lung function, oxygen saturation, and the exacerbation rate for lay public. The exacerbation rate is the infection or frequency what you get during the year with chronic respiratory disease, and there are guidelines of 2 or 3 per year. It's a more prone for moderate or severe cases of that chronic respiratory disease. And there is also categorization of the severity of the disease based on the lung function. So when we are looking at supporting people as a healthcare professional, policymakers, and the guidelines, into pointing on to these key indicators like lung function, oxygen saturation, exacerbation rate, but are we actually tackling the problem genuinely? Are we looking into people needs? Because what's missing currently is psychosocial care, because mind and lung are connected. And without screening people with anxiety, depression, or emotional distress, people cannot have that skills to manage it. And they are going to end up in the hospital corridors seeking for help because they have a fear or panic. And imagine that you're running in the park, and then you suddenly hit a rock and fell down, and you panic and you get breathless. And but you can recover if your lungs are healthy. But this is actually a situation for people with chronic respiratory disease whose airways are already compromised, whose airways are getting less oxygen already. And oxygen is key for our survival, even for our thinking process and our presence in this earth. So we have to understand how important it is to educate people and also to tailor psychosocial intervention for people with chronic respiratory disease. And as humans, we all have traumas in different forms and shapes throughout our life. And a trauma informed care is a key need for people with chronic respiratory disease because being breathless is already causing the psychological injuries, the anxiety and panic inside them. And a lot of different regions in our brains are compromised because of this. And there is a increased aging process due to lack of oxygen, and also because the people are trying to get into the management of their daily care, remembering all the medications, remembering all the inhalers, remembering all the doctor appointments. This aging process, lack of oxygen, also puts them into a key struggle to manage their conditions effectively. So that also leads them to make them feel that they are broken, and make them feel that they have nowhere to go and their life is going to end. And those sort of small triggers, negative triggers, causes cognitive dissonance in them, and that leads to a huge gap in the management of their condition effectively. So the key, what I want you to take away from the slide is we have to focus meaningful intervention, integrating psychosocial intervention in the care packages of people with chronic respiratory disease. And it should not be an unmet need anymore. After this webinar, I believe and hope so, that we start thinking of what are the psychological and social needs, unmet needs we can integrate into this chronic respiratory disease pathway to reduce the burden on the healthcare system. And as I already mentioned, pulmonary rehabilitation. There's nothing but the lung rehabilitation. It's a gold standard offered to people with chronic respiratory disease, and also there is actually a lag in prescribing this. People with moderate and severe stages are put into this, and there is a low referral rate. Less than 10% people are referred, which actually gives us an indication there is a huge lack of understanding, even among the healthcare professionals, to prompt that referral at the right time for the right people. And there's also, after referral, a high dropout in pulmonary rehabilitation. And maybe people are thinking that exercise is something which they can do. Or maybe people are getting bored doing that pursed lip breathing or the diaphragmatic breathing. Or people are getting bored with that educational session, which is not engaging them and also their families into that. So there might be several reasons, and several evidence papers have been published so far for the past 3 decades about the lack of care packages and lack of strategies, effective strategies to engage people in the pulmonary rehabilitation. So when we look at that, it is not a patient problem and patient is not engaging. It is a system problem where we are not offering a design that actually attracts the people to engage with it. And also, there are paper evidence that the format, location, and also the timing excludes the working age adults, which I wanted to mention specifically here because I'll be going through the survey data which we found out and the huge gap in those population. And so those are very key things which we have to understand when we look at how we can actually now have this public health communication around the psychosocial interventions in people with chronic respiratory disease. So I'm going to now reveal all the data, what we found out, the huge awareness gap about emotional breathlessness and which is poorly understood and underrecognized in the public health communication in UK. So as you can see on the screen, we put out a question where the public is aware of the mental health challenges. We specify specifically anxiety, depression, either or the both in people with chronic respiratory disease. The results came out, and we also explained that chronic respiratory disease includes COPD, asthma, interstitial lung disease, and more. And so we clearly communicated in the survey, and the results, what we found out was only 31% of people are aware of this link of mental health challenges and emotional well-being and breathlessness in people with chronic respiratory disease. And 69% of UK adults have low or no awareness, representing a huge, significant public health communication gap. So that 69% is broken down into 42% have low awareness and 27% is not aware at all. I give a moment for you to digest these figures. And if you want a detailed report, I have also actually linked up on the screen there the publication of 72 pages of survey reports. So you can go back after this webinar and take a deeper look on that publication. Now, importantly, from the survey, we also had very important details in the survey. And we looked into the demographics, the working population, the regions, and their life circumstances. So what we found out was certain groups show consistently low understanding of the mind-lung connection. And it is actually raising a urgent concern for targeted communication. So men, only 28% are aware, and that is below the national average, suggesting the gender specific communication barriers. And working age adults between 25 to 44, only 50% fall into this low awareness group, the largest and most economically active demographic. So they are actually having a low awareness about this important connection of mental health challenges in chronic respiratory disease. And married individuals, only 45% of people are able to only 45% of people have low awareness. It is actually a huge population gap where the health campaigns and the families are overlooking this important connection of the mind, lung, and mental challenges in chronic respiratory disease. And parents, importantly, 44% have low awareness. So it is actually a group with high daily stress, but limited engagement with mental and physical health links. Now, looking at this data, you might wonder, we have a lot of mental health campaigns. We have Rethink and all the other charity organization, the Mental Health Foundation, talking about anxiety, depression, and a lot of other important public health communication. But why do people then lack the importance of mental challenges in chronic respiratory disease? It's something importantly we have to think about. If the campaigns have been going and we are investing money in the campaigns and we are investing our people, healthcare professionals, investing their knowledge in helping people to understand, providing education. And in my channel from 2021, I'm shouting out loud about this important connection of mind and lung. Still, we have this huge gap of understanding in our UK public the link between mind and lung, the mental challenges in chronic respiratory disease. Very important concern. We have to think about how we can actually change this. And most importantly, the vulnerable population, the separated divorce, people have the highest awareness, 38%, saying that married people have low awareness, 45%. And parents, low awareness again, 44%. And the widowed individual have the highest not aware category. So 32% of people in that widowed category don't have awareness about this important mental challenges in chronic respiratory disease. And interestingly, the retired population and the not working group are not aware, 31%, both of them, ranging on that figure, are not aware of this important mental challenges in their chronic respiratory disease, which is again highly concerning. And we have to understand this important, huge gap and tailor public health communication to those population targeted, and also trying to think about along the lines of how we can develop a strategy in integrating the psychosocial intervention into the chronic respiratory care packages in wider UK. And as I already pointed out, the huge gap in the working age group and a productivity risk, 25 to 44 age group people, only 50 of them, 50%, not only, it is 50% have a low awareness bracket, unrecognized emotional breathlessness, which is contributing to the reduced productivity, delayed help seeking, and more of addictive behaviors, smoking behaviors, and wider well-being impact on poor understanding on their anxiety, creating that cycle of physical and emotional distress. So, looking at the data, the survey data, what we found out, there is a huge, huge communication imperative. So 69% of people are unaware. The message isn't reaching the people, though we are doing good work. Everyone is doing, investing their good work. We are not actually failing, but we are failing in the regions where our communication is not reaching the people in a right way. So this data signals a clear and urgent mandate. The public health communication must develop a targeted, accessible messaging that bridges the awareness gap, particularly for the groups which have a low awareness or not aware at all, men, working age adults, and those vulnerable at life circumstances, the widowed population. So, as I've explained in my slides earlier and also in my YouTube videos at my YouTube channel, Breathe and Thrive, I've explained this mind-lung cycle, and I would like to, again, reiterate in this webinar again, where people with the chronic respiratory disease, especially COPD, 80 to 90% of them account for smoking as a main cause of those disease. And many other factors play in the different forms of chronic respiratory disease, like emphysema and interstitial lung disease. But when you talk about chronic obstructive pulmonary disease, smoking is a primary cause. And when you're taking those population, the smoking increases their lung damage. At the same time, it also increases their anxiety more, though they actually feed in smoking for their anxiety, thinking that that would actually eradicate the anxiety, but it is the reverse that is actually increasing the anxiety and reversing the damage. And that increases their breathlessness and fear, which then further gets into their avoidance, social avoidance, and deconditioning of their body and mind, and also isolation and the well-being factor is there, and that's impacted hugely in this population. So, breaking the cycle requires a simultaneous intervention at the psychological and a physical level. So, we are giving that physical level of care. We are investing hugely on that, but we have to integrate the psychosocial level of care into this population. So, as I mentioned earlier, to reiterate in the slide, the connection of smoking and mental health with the COPD. So, 80 to 90% of COPD is linked to smoking, and it remains as a dominant modifiable risk factor. But its cessation is profoundly shaped by the mental health status. So, people are seeking smoking because they are running away from their mental health issues, from their own traumas. And the individual's depression are significantly more likely to develop COPD as well, independent of the smoking behavior. So anxiety drives is a primary driver of smoking. So cessation program, though huge amount of efforts and money are invested by the government and the people, they're ignoring that structured trauma-informed mental health care into those smoking cessation programs, which actually lowers the success rate. The patches or the tablets, whatever they take, is not going to reverse anything permanently. The root cause is not resolved yet in those programs. So we have to think along the lines how we can integrate psychosocial skills into those packages when you're training people to change their behavior, because our behaviors are driven by our mind. And if your mind is not actually learning the strategy to change that behavior, how much ever you're investing in education, how much ever you're offering that prescription for in the smoking cessation program of 6 weeks program widely in UK, it's not going to make any effective changes, and the changes are going to be temporary, and they are going to be back in square one after the 6 months or even 4 months down the line. And we also found out there is regional inequalities of this mental health challenges, the mind-lung connection in the chronic respiratory disease. Approximately 40 to 50% of the population with the lowest understanding is around the northern regions of UK and Midlands and London. To my surprise, London was having the lowest awareness of this connection of the chronic respiratory disease and mental health challenges, and they have only a surface level of understanding. So, what is that going to lead to? What is the consequence of it? People are going to have a delayed health seeking patterns. So, they are going to minimize or misattribute their symptoms, postponing their presentation until the crisis point, until they reach that severe lung stage. And the fragmented care or the poor self management without the integration of psychological integration and combining the physical and mental health services, delivering at the moment at a separate services and not referring at the right time to the mental health services as well, is going to have a huge gap in the care and increase admission and reduce quality of life. Obviously, when fragmented care, poor self management exists, then there is going to be more emergency attendance, more inpatient days, and measurably it's going to worsen the lives of people. So we have to focus on the needs of the individual people and integrate that psychosocial intervention into their care packages. So, very specific point here on the slide, geography compounds inequality as well, where awareness is lowest and service is often most stretched out. So we are burdened with NHS burnout, but we have to think now how we can reduce the burnout by incorporating strategies that will help people to handle their emotional breathlessness in this chronic respiratory population. Now, I wanted to focus on the slide more on the social determinants of awareness. And if you're a healthcare professional or policymaker listening to this might be a very important slide you need to open your ears to. And if you're a lay public, it is also important, I would say, because you need to know that what are the factors that is impacting your perception of care in the lung rehabilitation or the respiratory care delivered to you if you're a person or a carer with chronic respiratory disease. So awareness of emotional breathlessness does not distribute randomly, so it mirrors the broader landscape of health inequalities. So health literacy plays a very key important role. So people offer medication. Let's start, which is existing in the practice. They are offered inhalers and prescribed inhalers, and people have been demonstrated once, maybe, or on the revisit, maybe. But do they remember the labels or the names of the inhalers? Do they remember why they are taking that? And how this is communicated to people? What is the understanding levels of the people? When the literacy level, health literacy level focused on in many of the settings, the focus is more on the language communication. I would say the focus should be more on the culturally sensitive language communication because language wide across, English being the common language worldwide, most of the people are able to understand in English. I'm not saying or discounting people who are not able to understand English, but still, even in a wider, huge population being able to understand English, still, we're not having that communication reaching to the population, which our survey indicates 69% of population are not aware of this important connection, mental health challenges and chronic respiratory disease. So where is the gap? Is it existing? We are doubling the disadvantage as well. So we need to actually form targeted materials for communication, digital, both, and manual as well, and how often the frequency of communication should reach those population also should be the key focus when we're focusing on the health literacy level. And second point, which I wanted to focus here, is the service access. Physical and psychological distance from the services, whether the geography or the culture or the system shapes who receives the support and who does not receive the support, and which is very important point I want you to think upon, because it is not about bringing the care close to people's home. Maybe you have enrolled to the gym as a New Year resolution, which is close next door to you, but your motivation level stays up maybe 1 or 2 months, and then it just fades away. So it is not about the proximity of that solution to you. It is about how importance of that solution being communicated to you. And also the service access matters, the distance matters. I'm not discounting that, but the communication of the importance level of that is very importance of that social intervention or the rehabilitation, what you're offering to the people is very importantly need to be communicated in a right way. And the socioeconomic factors. Deprivation correlates directly both higher disease burden and low awareness. And our survey confirms that a huge communication gap exists, and 69% of population are not aware of the mental health challenges in chronic respiratory disease. So, which is linked to the emotional breathlessness. So, it's not only a clinical problem we have to look into the emotional breathlessness. We have to look emotional breathlessness as an equity issue requiring a population health response. So I want you to now take a moment of pause and calmly sit in your place wherever you are and take a breath in through your nose and breathe out. Now, as you're closing your eyes and observing your own breath, check whether your breath has got more stressed by listening to these data, whether your mind has recognized the problem, what is currently existing, and how we are going to help to design a solution for this problem. So I want your emotions to play right now and also manage your breathing. Tell yourself, this is an urgent problem, but I don't need to panic. This is an urgent problem, but I need to invest my right thinking in designing the solution to this problem. Whether you're a public, whether you're a person with a chronic respiratory disease, or a policymaker or healthcare professional, whoever you might be at this minute, whatever may be your title, presently, you can understand your presence is determined by your breath. And I want you to focus and understand and put yourself in the shoes of people with chronic respiratory disease and how they struggle with this anxiety and depression alongside with their physiological changes in their lung function, and how helpful it would be if we could think along the lines of integrating the psychosocial intervention in our care packages, which will help us to focus on the needs of the people and prepare their skills to manage their condition. Where most of the chronic respiratory disease focus on, or any chronic illnesses focus on self management. And we have this chronic cry that people are not engaging in self management. But we have to think now along those lines how we can modify the packages of rehabilitation to people with chronic respiratory disease and make them engage in that rehabilitation so that they can rehabilitate both their lung and the mind and renew their life. Now, I'm going to take you to the following slides. I hope that you had a moment to realize the importance of emotional breathlessness and how to tackle it in the population of chronic respiratory disease. So, I wanted to now focus on the slides before. I focused on the urgency and the importance of emotional breathlessness. Now, I want to focus on emotional breathlessness as a modifiable determinant factor. You have to treat emotional breathlessness as a pain because your lung cannot cry, but it is crying loudly in the forms of anxiety, breathlessness. And we have to recognize emotional breathlessness similar to pain and screen it, document it, and address at every clinical encounter when the patient is coming to you. And when you, if you're a patient, tell your doctor or a healthcare professional, whoever you're dealing with, how many times you got anxious, how many times you're depressed, which you have recorded in your diary. So that might actually give them important information that you're struggling with psychological issue along with your lung function. So it is very, very important that both the patient and the doctor need to work congruently together to find a solution to address this emotional breathlessness, which is a modifiable determinant. So awareness is very, very key. And there it comes the public health education, how we are going to tailor the information to reach the public to understand, even the person who is not literate, to understand the importance of emotional breathlessness in chronic respiratory disease. And so early recognition is going to interrupt that mind-lung cycle, which I explained earlier, which is sabotaging their lung function and mind and well-being. It can actually be brought back into a more structured format where people can engage in their self-management. So we have to integrate, bridge the gap. So the current NHS, which I already mentioned, the pathways are more focused on their physical intervention. So the mental health is provided as a separate service, and anxiety or depression is more related to a generic format, not as something linked with a chronic illness or breathlessness. So what then patient receives if the system is fragmented is a disconnected care, no single pathway joining their physical and emotional needs, delayed support psychological distress increases their disease progression as well. So it is key important that we are going to focus on integration of the physical and mental health into the care packages of chronic respiratory disease. So I've already mentioned in my earlier slides, the case for integration is very strong. There's economic case and a health inequality case as well. So the system gaps, no routine psychological, psychosocial assessment and respiratory care pathways, absence of trauma-informed care frameworks, lack of integrating commissioning structures across the integrated care system boundaries, and the economic cost of it is more of increased admissions and increased relapse rate. To reverse this, we need to integrate the mental health and the physical health into the respiratory care pathways so that we get a fewer admissions, reduce unplanned hospital attendance and the A&E presentation, and also lowers the relapse rates and provides sustained care recovery, reduces the repeat referrals and crisis episode. And also there is evidence showing that models of economic cost modeling, integration of the physical and mental health care into the chronic illnesses model, especially the long-term conditions, saves between 100 to 400 million pounds per year. So it is a very wise investment if we are going to invest in integrating this psychological and the physical health needs into the care packages for the people. So that might actually help us to help the patients adhere to their care engagement, like rehabilitation program or medical management, whatever they're engaged with, improve their mental health and like depression, anxiety, and their breathlessness related fear, and it's going to improve their quality of life. The holistic care what we're providing will improve their functional outcomes and their reported well-being scores as well. So a shift needs to happen in how we care. Currently, our care packages or the NHS care is more of a reactive to the crisis care, more fragmented, physical only responses. So there need to be immediate stabilization of treating acute episode as they arise. That is what we're operating between. So we need to focus on the preventive integration, proactive, connected care pathways, and integrating more of the mind-body holistic care, emotionally informed care to the people, and more focused on what the person needs. More person-centered support should be integrated, not a tick box exercises or a generic care, what an individual needs. And so this is not a minor adjustment to the existing pathway. It is a structural and a cultural transformation in how the respiratory health should be understood, funded, and delivered. So, in my publication, I've actually populated the policy recommendation, and you can go back and read in your own time after this webinar. But just as a snapshot, where the care, the policy changes needs to happen, where we need to close the integration gaps. So, at all levels, national, regional, and local, the Department of Health and Social Care, the NHS England, should set an integrated respiratory and mental health policy and funding frameworks for that. At regional level, the integrated care systems, the ICS boards, should actually commission psychosocially integrated pulmonary rehabilitation across the pathways, initially beginning with the pilot programs to prove the case and then go for a larger funding models. And locally, the community and the voluntary care social enterprise, that is VCSE organization, should deliver a culturally sensitive and accessible support. So what are the five key policy actions I recommended in this publication of the report? Is number one is a routine mental health screening embedded in the respiratory care pathways. Number two is funding the psychosocially integrated pulmonary rehabilitation at a scale as the pilot at the initial and then for a long-term programs. And number three, training the workforces, the healthcare workforces in the trauma-informed care approaches. And that will help to timely referral for the right people to the right healthcare professionals. And launching, number four, launching a national awareness campaign on the emotional breathlessness to create that awareness of the mental health challenges in chronic respiratory disease. And this is very key, I wanted to stress. I've actually started to advocate a campaign since 2024, and I have been circulating widely in my social media and through my networks as well. But getting a responses where it's not reaching to the extent what it required to be. And I would, after this webinar, I would invite you all to look at the campaigns populated in my social media and my Facebook, therapies, or to the change.org campaigns. Look at the integrate mental health into the Gloucestershire population or the emotional breathlessness crisis population. And also, I populated my campaigns in my YouTube Breathe and Thrive. So, why I'm actually stressing and taking time to explain this is I need the support of the population to help to make this vision true, help to reform the care what we are presently providing to our population of people. So it has both the person-centered benefits and also the economic benefits and reduces the health inequalities across wider UK. So it's key that if you are really able to understand so far the concerns revealed and the solutions needed, please do support after this webinar signing up those campaigns. Now, finally, the fifth ask of the policy is to scale the community programs to reach the under-researched population. Now, when we talk about the culturally sensitive and accessible delivery modes, more I focus on which I'm presently delivering to the population. You can come up with your own creative ideas, but this is something which we have actually delivered to population, found, received the feedback, they found it very helpful. So some of them are the bread cafes, where we invite people for a coffee and we provide them coffee, and also the information is delivered to the people about the importance of the connection between mind and lung. And the second one is the breath art, creative art, as our mind registers something which we are creating, either in the form of an art or writing. So we wanted to use that method to help people to understand the connection between mind and lung. So we have actually administered the session of breath art, Canvas breath art, helping people to understand how to emotionally express your breathlessness in your canvas painting, and choosing the color and the link of color to emotions and breathing. And that went well. We got a good feedback, and we will be delivering a few more in this year. And other methods are the digital inclusion hubs, that is actually focusing on digital materials like YouTube education or campaigns or similar things which people can focus on. And culturally sensitive model should be co-designed with the communities and maybe populating some surveys. What is that they would like to engage in might be something we need to think along those lines for the engagement. Now, in my publication of the report on the page 11, I've actually populated this national implementation partners, and you can go and have a look at those partners who can support the implementation of this vision of emotional breathlessness, integrating the physical and psychosocial skills in the care delivery of chronic respiratory disease. Now, the important question I want you to think about is what will you do differently after today? So, whoever you are, a clinician, a commissioner, or a community leader, you have the power to change what care looks like for patients living with emotional breathlessness. I've delivered the evidence so far in this webinar and also the economic case, what it requires to be. The question is, will emotional breathlessness real, common, and clinically significant, and it is treatable and also modifiable determinant. So integrated care is not a luxury, it is a standard we owe to our patients. So this is something, a message I wanted to be deeply ingrained in you. At this minute, you're listening or watching this, it is very, very important that we think along those lines, how we can change this huge communication gap of 69% of population not aware of emotional breathlessness and how it is impacting their lives and our NHS economic spending on chronic respiratory disease is something important what we need to think about to change the situation. So the final call is UK breath is not just physical, it's emotional, psychological, social, and lived, which we have been talking now. I have been talking now so far, and I hope so that message has ingrained in your minds. So the call, what I'm putting out to the UK government is emotional breathlessness should be recognized as a public health priority and a patient safety issue. So though the clinicians, or if you're a clinicians or policymakers or the community, you're all though working together to change and deliver good care to people, we need to focus on integration of the mental health and trauma-informed approaches in the care packages of people with chronic respiratory disease to raise awareness, reduce stigma, and champion the equitable access for all patients. So far, the report has been disseminated to the Integrated Care Board, ICB, in the Gloucestershire, to our local MP of Gloucester, and to the Chief Medical Officer of Gloucestershire, to the Voluntary VCSE Alliance in Gloucestershire, the UK Parliament in the House of Commons, the Department of Health and Social Care, and the Royal College of Physicians, RCPs London, Asthma and Lung UK, European Respiratory Society, and also along the lines of BBC sent an email to deliver a session in their in the radio show about the importance of the report. So I put on the emails in November 2025, and the follow-ups have been made in Jan and March as well to some of those who have been sent in earlier in November 2025. And I'm continuing to follow up on those um, um, briefings which I can provide for those people, and I've not had heard from them. And this is also getting published in the global health journals as well. So the key importance, what I wanted to make here, important call I make here is emotional breathlessness is not something we can take it lightly. And our mind and lungs are connected. And we are investing our resources or the funding in a direction where it is not helping people. And we need to redirect our resources where it makes sense to people and people can engage sensibly in the respiratory care management and rehabilitation management in chronic respiratory disease. So, with that being said, you can take a look at the full publication, which is 72 pages down, and you can take your time, and you can post your questions to me later on to sdevi@tele-therapies.org if you have any questions related, and all the details also provided inside the report. So you can contact me with any of your questions. And I'm also inviting collaborators on the funding for this, and I would welcome some collaborators on the funding for pilot projects. So please do contact me if you are keen in engaging with this project. Now, thank you for your mindful presence, and I hope that you got the important message of emotional breathlessness and our survey, which confirms there is a huge gap of understanding mental health challenges in chronic respiratory disease among the UK public. So thank you again, and I will see you in my next webinar on the 9th of April in the Trauma Informed Care. Thank you. Have a good day.